Hi there, I'm here with Professor Mark Walterfang, who is a psychiatrist and neuropsychiatrist. And today we're going to talk about what is the difference between a neuropsychiatrist and a neuropsychologist. So, Professor, would you mind elaborating for us?
Absolutely. So a neuropsychiatrist is a clinical psychiatrist who has training and expertise in neuropsychiatry, which is really about the interface between psychiatric disorders and more coarse brain disease or brain disorders. So the sorts of things that we would have a strong interest in particular would be, for example, things like delirium, dementia, neurodegenerative disorders, just about anything that affects the brain. So people that might have a history of acquired brain injury, for example, that's particularly our domain, but also the interface between neurological dysfunction and psychiatric illness, which can be bidirectional. So, for example, in functional neurological disorders, people that have non-epileptic form seizures, for example, or who might have functional weakness. In addition to that, a neuropsychiatrist will always have expertise in cognition. I've been working in this space for almost 25 years, and at the beginning of that time, I developed a cognitive assessment tool called the NewCog, which is now being commercialized and is available in the Apple Store, for example, and that provides a very thorough bedside cognitive assessment that I routinely do clinically, and have probably done more than 10,000 times over the course of my career, and continue to do a number of times each week in public and private medical settings. But also, in my role as a neuropsychiatrist, I work regularly with clinical neuropsychologists. And what that means is I've had at both a clinical and research level a great understanding of the role of neuropsychology in taking a deeper dive into cognition, but also as a psychiatrist, how to integrate that with daily functioning, how to understand that in the context of illness, whether that might be a mood disorder such as depression or post-traumatic stress disorder, or a major psychiatric illness such as schizophrenia or bipolar disorder, really understanding what are the presentations and concomitants of that. And probably one additional thing that neuropsychiatrists are often strongly involved in is also neuroimaging, being able to understand and interpret neuroimaging, particularly magnetic resonance imaging or MRI, but also functional neuroimaging such as PET scans, and understanding how abnormalities in those may actually be relevant to an individual's presentation and how it might indicate or signify the degree of impairment and the role that organic brain disease plays in someone's psychiatric or cognitive presentation. So I think a neuropsychiatrist is uniquely placed to really integrate all the biological information and understanding of psychiatric illness, psychological illness, other aspects of medicine, whether that might be, for example, dementia, chronic kidney disease, heart failure, diabetes, and then how someone functions cognitively and how that might then be reflected in biological tests such as neuroimaging in particular. So I think we have that capacity to really integrate all of those things, particularly in complex patients and complex individuals.
So from a referrer's perspective, many would be familiar with sending an individual for a neuropsychological assessment. How does what you do differ to a neuropsychologist in terms of requirements for testing? And do you recommend that an individual who comes to see you has already had neuropsychological testing undertaken?
It's an excellent question, and it really depends on the clinical situation. I work with a number of neuropsychologists in both public and private settings, and think that they're really can be an essential part of a thorough assessment of a patient. Often what I will do in clinical practice is undertake a cognitive assessment, and the work that I might do in my time with someone might involve not just psychiatric history taking, a mental state examination, but also a cognitive assessment and potentially a neurological examination as well. So by its nature, my cognitive assessment will be more constrained than a formal neuropsychological assessment. But often the way that I will do my cognitive assessment, and particularly if I use the NewCog, the cognitive screening tool that I developed almost 25 years ago, we know from our research that that's highly predictive of how someone will function neuropsychologically. So I think being able to utilize the new cog gives me a fairly good sense of an individual's level of functioning. But if there are still questions that I don't have an answer to, I will often then refer to a clinical neuropsychologist for a more thorough, in-depth assessment of that patient's individual functioning. Having said that, in some circumstances, if there is real concern about someone's neuropsychological functioning, their cognition, it's potentially an advantage to me to have the results of testing available to me before I see someone, because I can then really integrate that in a full and thorough understanding of someone that I'm seeing.
So I guess for our referrers, if in doubt, contact you and ask whether you'd recommend that neuropsychological testing be done prior, or whether, based on the details that you have for the individual, whether it's required or not, essentially.
That's right. And there may be situations where in someone's clinical assessment, there's already been a recent or contemporaneous neuropsychological assessment, and often that doesn't need to be repeated. But if it's more distal in time, and if there's concerns about a change in functioning, then sometimes it can be quite helpful to have that done. And I'm always happy to provide advice on what's the best path to ultimately lead to the best assessment.
So, Professor, for any referrers who have concerns about an examinee's cognition, what kind of documentation or investigations might be required prior to coming to see somebody like yourself?
It's a good question. If there have been concerns about cognition in the past, then people may have been assessed previously. So having access to past cognitive testing that might be undertaken, for example, by a geriatrician, they may indeed have had past neuropsychological assessment. That's incredibly useful to have on hand to integrate with other findings, and sometimes cognitive assessment that I might do in an examination of a patient. In some circumstances, if there isn't contemporaneous or really recent assessment of cognition, then it may be useful to think about whether someone needs to be reassessed. The sort of assessment that I do, effectively a bedside assessment test or a cognitive screen that takes about half an hour, can give a good overview of areas of difficulty. But particularly if there's a question about return to work, and particularly if it's something that's a cognitively demanding role, such as the professions, for example, then I think in that situation, if we don't have recent or contemporaneous assessment that gives us a finer grained understanding of that, then it can be useful to look at getting formal neuropsychological assessment. Absolutely.
Thank you for that. So I guess the take-home message is, if in doubt, reach out and ask what it is that you might need prior to seeing an individual. And of course, for all our referrers, that can be done very easily through the MEDirect platform. Thank you, Professor Walterfang. We'll speak to you again soon.
Thanks, Sue.